that's done, and also the Excel Centers, which is high schools for people 19 and above to get their high school degree, not a GED, their degree in a certification. But Jim is one of the most respected not-for-profit execs, certainly that I know. Can't believe that he was Georgia Tech guy, though. Careful. Ashley Overley is the CEO of Eskenazi Health Midtown Community. She has got a resume that's unbelievable. She's a graduate of IU School of Medicine. She has more than, let's see. Has served as the Assistant Medical Director for the Indiana Division of Mental Health and Addiction, and is a member of the American Association of Community Psychiatry and American Psychiatric Association. That Eskenazi Health Midtown has been around since 1969. So she did a fellowship in public psychiatry at Columbia, and she's an amazing woman. So thank you for Paul for participating, and Matthew, I'll turn it over to you.
Thanks, John. No one's going to get my last name. People always ask me, so I got to have it right there. My name is Matthew Indy. I'm our organizational project manager for Fairbanks. I've been here since 2011. I'm also the vice chair of the Indiana Recovery Council for the state and serve as a member of MAPAC, which is the Mental Health and Addiction Planning and Advisory Council for the state of Indiana. I work with quite a few different advocacy partners that work across the state to do mental health and drug addiction advocacy. And I'm also a person in long-term recovery. So this is a thing that's very near and dear to me. So I'm grateful that you all are able to come here and participate and get a little education about things that are going on in our community with substance use disorder and mental health. So our first question that we want to start the day off with is kind of why are we here? What's really going on in our community when it comes to drug addiction in the state of Indiana? So we want to talk about what's the problem. So we're going to try and get time going. So we have about 10 minutes per question. We'll see how our expert panels do at keeping a timeline. So I'm going to let Jim kind of kick us off here and just kind of dive into what is the problem that we're facing today.
Well, when we came into this 3 years ago, state, our primary focus was opioids, and it still is, although there's been a huge resurgence in meth use in Indiana and across the country. It's really the #1 drug now of use. It won't kill you as fast as fentanyl, but it's very effective at destroying lives. So you can see up here on this slide the number of people who died in 2017, which was a peak year. 2018, we had a decline of approximately 13%. Marion County, roughly the same percentages. And so that's the good news. You can look at CDC provisional data, and it looks like our death rate in Indiana from overdoses, and this is all overdoses, overdoses from all drugs, and there's a lot of polysubstance use. It peaked in November of 2017. It's been a gradual decline since then. So we still have a long way to go, but at least we've kind of bent the curve downward, and it's moving in the right direction finally after a long period of steep increases. But there's something here that I think we really need to all understand, and that's there was a study that was published last year out of the University of Pittsburgh. A couple of researchers plotted the drug-related mortality rate in this country from 1979 to 2016. How many deaths per 100,000 people? Here's the stunning aspect of that, and it really just stunned me when I saw the curve, because it follows almost perfectly an exponential curve, doubling every 8 to 9 years for almost 4 decades. The primary drugs involved change. The demographics of the populations most affected change. the geographic hotspots changed, and yet the drug-related mortality rate in the United States has gone from about 1 per 100,000 people in 1979, and that's as far back as they really had good data that they could count on, and that's why they stopped, that's why they used 1979 to start going to this, from about 1 per 100,000 people in 1979 to about 17 per 100,000 people in 2016. So we have, what that says to me is there are some underlying issues here that we as a society are not effectively addressing, and we need to get with it. We can talk about that a little bit more, but I think what you'll find from any of us could talk for the entire time about all this stuff, and you don't want us doing that, so I'm going to stop. Let Robin and Ashley chime in here.
Thank you, Jim. Dr. Overly, you want to jump in?
All right, so, well, I'll echo again some of the numbers that Jim said. I think it is interesting to note that 2017, we really peaked and saw the peak of overdose deaths here in Marion County. We dropped 11% in 2018. It's the first drop that we've seen since 2010, actually, in overdose deaths. And so that's very consistent with national trends. For reference, at the peak in 2017, there were 365 fatalities in Marion County. And just to put that a little bit in perspective, that's about 4 times the average number of yearly traffic fatalities that we have in Marion County. And to put a little bit of additional perspective around the scope of what can we as one institution in our county do to mitigate that number, we are estimating, I'm estimating a little bit based on some numbers from national surveys. If we're estimating that there are about 1% of the population has opioid use disorder, so there would be about 9,000 people with an opioid use disorder in Marion County. And with our treatment programs kind of maxed out, seeing as many people as we are possibly able to see, we're able to see about 15% of the Marion County residents with opioid use disorder. So that still leaves a lot of people. Obviously, we're not the only treatment provider, thankfully, but this is something that we really do need all hands on deck from across our county to be able to reach all those individuals that have needs. I think also it's important to note that of the individuals that we are treating for actually any addictive disorder, 75% of them also have an additional mental health diagnosis. I think it's important to note that I don't conceptualize addiction as something separate than mental illness. It is a mental illness, and so we really do put those in the same umbrella. When we're talking about individuals suffering from addiction, we're talking about individuals that suffer from other mental illnesses by and large as well. Also, I think it's important to know that that treatment works. So for people coming into our treatment programs, within the first year of services, 75% of them are able to eliminate the use of any illegal substance. So that's really huge progress. I think another great indicator of success is that initially when they enter treatment, about 30% of them are employed, and then within 6 months, 52% of them are employed. So we're helping them get back to a level of functioning within the community and within their families that is a really important part of their recovery and their progress.
Good. Yeah. Well, I think I just want to add to that a little bit of conversation about, we talk a lot about the opiate epidemic, and it's really kind of came at us in 3 waves as we've seen it. First with prescription opiates that we've heard a lot of talk about, and then with, after that, we've kind of seen an insurgence in heroin, and then what's really, really become ultimately the most scary part of this epidemic is the synthetic and fentanyl that's coming in. So, as Jim had mentioned, you know, the drug of choice has changed. There's a lot of methamphetamine, but what we're seeing now is that there's a lot of synthetics in all of the drugs. So, at one point in time, we were kind of seeing this, kind of going back to the stuff issue, we were kind of seeing this in suburban areas, kind of young adult males were kind of the predominant clients that we were kind of seeing were the largest group that were abusing opiates. Not that there weren't other groups, but that was kind of the targeted group. But now we're seeing it kind of spread. I think the highest, or not the highest, it's still young white males that are overdosing at the largest rates, but the fastest growing population for overdoses in the urban populations, because now there's fentanyl in crack cocaine, there's fentanyl in methamphetamine, there's fentanyl in almost anything, because it's very cheap and it can be exported. It can be imported very easily. It's hard to detect, so it's becoming a real issue to get behind this synthetic, as well as the synthetics that we're seeing with spikes. And so the synthetics are kind of a new wave of a drug addiction that, as everyone pointed out, I've been around for a long time. This is not something we saw 25 years. We had a crack cocaine epidemic, but we did not have this fentanyl kind of coming in, which is kind of a whole new issue that I'm sure we'd like to talk about. And the other thing I just kind of want to piggyback on is that Fairbanks, still the number one reason someone admits into treatment, their primary drug of choice, although opiates is a close second, is still alcohol use disorder. And I think one of the things that we forget is that as addiction works in the brain, it doesn't necessarily matter what you're addicted to. And many, many people are addicted to alcohol. So when we talk about gateway drugs, alcohol needs to be included in those conversations. And so I just want to make sure that we talk about this as, we're talking about people, and we're talking about a dynamic, a mental illness dynamic that can start with a variety of drugs, but now we've got some that are more complicated to treat, more complicated to get a control over.
You talk about fentanyl and how you see so many different drugs in toxicology reports.
Right.
People who have died of overdoses, but there's a mixing of stimulants and depressants,
Absolutely.
which is still kind of mind-boggling to me.
Yeah.
But that's what you're getting when you see meth and fentanyl together,
Yes.
cocaine and fentanyl together.
Yeah.
It's really kind of amazing. But to give you some idea, and by the way, the meth today is not the stuff. Now there was a report of an arrest, or I guess it was a conviction of someone who was making meth in a kitchen lab or something. That's not the norm anymore. The meth today that's so prevalent in Indiana and around the country is manufactured. It's mass produced in Mexico. It's coming up. It's high in purity. It's very low in price, and it's everywhere. The fentanyl, most of it's coming from China. You can order it on the dark web. You can buy a kilo of fentanyl for a few $1,000s. You can turn it into $2 million on the streets. A Ziploc bag of fentanyl. This was an article I read a couple of weeks ago, and it was just kind of a stunning image. A Ziploc bag of fentanyl will pay for your college education, and you'll have money left over for a house and a car. That's how profitable this stuff is. Now, and what that says is the people who are behind this, because there's so much money involved, will do anything they can to go over, under, around, or through any barrier that we put up. We will not solve this problem by focusing solely on the supply side. We don't want to make it easy for people to do this kind of business, certainly. But what I think the challenge for our society is to find ways to reduce the long-term demand. And that's a totally different issue. My guess is it would take a generation if we did everything right, which we won't do. So we have a lot of work to do on that front. We can talk about that later.
Yeah, I think that's a perfect segue. I think the next question we want to really take a look at is kind of how did this happen? What's the cause of these problems? And kind of why now are these problems such a powerful force in society? You touched a little bit on that, but actually you want to kick something?
Yeah, although actually, can I ask you to go back to the other slide real quick? Could you click on this website here? Well, just before we move on from the scope of the problem, I do want to highlight a tool and a resource that I think is really cool that I just want to make people aware of that's through ISDH. And maybe we can look at it here.
Okay.
That will pull it up for us here. So, so I'm really impressed with this website. So through this website, you can select through by county to find data on what programs are available in different counties. You can find data on numbers of opioid prescriptions, number of hospital discharges, and number of deaths across different years. And so I'm really impressed actually at how sophisticated this is. This is what I was looking at this afternoon in order to update my data. And so I think this is it's just a very cool resource for people to be aware of.
Ken George back there is smiling because
He did not put me
Tim,
up to
Tim,
this.
Tim works in governor's office and has really been point person on a lot of the
I'm
data.
glad you're pointing to state data.
So this website was not included in the packets that we provided to you, but I'll make sure that Don gets this link so that we can kind of kick it out to everybody who's involved.
Right, so I'm very impressed. You can see graphs with the trends over time. You can compare our county to the state, or we can compare Marion County to state averages. So it is pretty cool. So if you're curious and want to learn more, or if you have a presentation to do at some point, then this is a great place to go. But back to addiction. What's the cause of addiction? So I'm a physician. I'm a psychiatrist, and so I'm going to speak for a little bit with my physician hat on right now. As a caveat, I am a generally trained psychiatrist, and so addiction is not my specialty. I don't only see individuals with addiction, but this is something that every psychiatrist receives training in. So we think they should receive more training in it. So what I think it's important to start with just some basic education about addiction. I think within society there's a lot of misunderstandings and misconceptions of what addiction actually is. And so I'll talk just very basically about what we know that addiction is. So it's a chronic, relapsing disease of the brain that results in compulsive and difficult to control use of addictive substances despite harmful consequences. And it's used despite harmful consequences that really is a key feature of the disease. We know that addictive drugs cause specific changes in the brain with repeated exposure over time. And so some three key changes that happen in the brain are: one is a desensitization of reward pathways. So for healthy individuals, you receive reward stimulus with sort of everyday activities that are healthy and responsible. So for example, you complete something on your to-do list, dopamine. So that felt good. You completed something. You got something done. You took a shower. You feel nice and clean. Dopamine. You're getting a reward. That's something that's positive. Your brain actually reinforces that healthy behavior. You saw a friend. You ate lunch. You feel good. These are all things that your brain responds to with positive reward. So for individuals who are suffering from addiction, their ability to feel that pleasure and subsequently the motivation to pursue those behaviors is decreased actually. And then on the negative side, they actually have an increased response to stress. And so they actually feel increased discord. They actually feel more negatively with stressful situations that actually increase their craving for the drug, which is the thing that does give them positive reinforcement and that does give them a reward. And so along with those two sides of the motivational responses that they get, there are also weakenings of the brain in the areas that are responsible for executive functioning, such as decision-making and impulse control and self-regulation. And so it's that pairing of the decreased positive reinforcement for normal everyday things, increased stress, and then reduced ability to make decisions leads to behavior that consistently seeks out addictive substances. And so we do, again, it's important to know that it is actually a disorder that is rooted in brain dysfunction. In terms of how we diagnose addiction, even though it is a brain disorder, there's not an imaging test that we do that diagnoses it. It really is a clinical diagnosis, and so we diagnose it by talking to a person understanding their history of behavior, gathering collateral information. Sometimes tests can give us information about whether a person has used a substance, but that doesn't necessarily make the diagnosis. The diagnosis is based on a pattern of use that leads to dysfunction over time. And so a person can use a substance that is addictive and not meet criteria for an addiction disorder. And so it's not defined by a specific frequency of use. So for example, you could smoke marijuana every day and not meet criteria for a use disorder. But once you pair that with a pattern of use that is dysfunctional, then that is the point at which it becomes a disorder.
Robin, do you want to jump in here?
Well, could I just go on, yeah, I appreciate that. Going back to the causes, I think one of the things we need to talk about, we used to say it doesn't matter, they're addicted, it doesn't matter why or how, but I think we've learned it matters a lot. And what we know is that most people who suffer from addiction, they talk, in order to get into recovery, they have to find purpose and meaning. And I think for this group, this is what you're doing. You're serving a purpose. You have purpose and meaning in your life. For people struggling with addiction, a lot of times that's lost. There's a loss of the sense of community. There's a loss of, there's the secondary diagnosis that Dr. Overly talked about, severe anxiety and depression. We know not only do we have an addiction epidemic in this country, we have an anxiety and depression epidemic. There's a loneliness epidemic. We have loss of purpose and meaning. And so we know that in order for someone to get well from addiction, not only do we have to treat the biological aspects of the disease, but we have to treat the root cause. And one of the things, and I know Jim's going to talk about this, but this is something that we've actually started to develop a lot of programs around, and that is the treatment of trauma. 100% of the women at Dove Recovery House have experienced some sort of some sort of physical or sexual abuse. 2 out of 3 of the women that enter treatment have experienced some sort of physical or sexual abuse. Trauma, it has been something we haven't, childhood trauma, we're going to talk about that here, I think, but we aren't dealing with the core issues as this question, we're not going to deal with this addiction epidemic. And so I feel very passionately about that. Treatment is more about not just treating the addiction, and prevention is not just about learning to say no to drugs, it's about what's going on with you. If you look at, and if you have a chance and you're interested, monitoring the future, it studies adolescents, and we treat adolescents here. And if you ask them why they use, these are children that are suffering from serious emotional depression and anxiety issues, and they're using to medicate their feelings so that they don't feel the pain anymore. Or sometimes it's just they don't feel like they fit in, and they can fit in with the group that are using. And so they would choose to be doing something self-destructive than being isolated and alone. So there's a lot of psychosocial components to this disease that I think are going to be critical in our conversations about how to address this epidemic.
Absolutely. I want to quote from a report on a study done at Syracuse University. It was published in March of 2018. The researchers mapped about 515,000 drug-related deaths from 2005 to 2016. They compared them county by county with various social and economic factors. And I'm going to read from the report. Controlling for county demographic characteristics. Average mortality rates were significantly higher in counties with greater economic and family distress, including rates of poverty, unemployment, disability, no college degree, public assistance, rental stress, divorce or separation, and single-parent families. Average mortality rates were significantly lower in counties, get this, with a larger presence of religious establishments, a greater percentage of recent in-migrants, more dynamic communities was the explanation for that, and counties with economies reliant on public or government sector employment, more stable incomes. Counties with a larger presence of religious establishments, again, this is quoted from the report, have lower drug-related mortality rates. Opportunities for fellowship and civic engagement through religious organizations may facilitate social interactions, trust, and social cohesion, and increase residents' sense of belonging. And one of the researchers' conclusions was that religious establishments may play an important social capital promoting role in the fight against the current U.S. drug epidemic. Now, let me go from that to ACEs, trauma, especially in childhood. How many of you are familiar with the ACE study, the Adverse Childhood Experience study that was done by the CDC and Kaiser Permanente back in the mid-90s? Okay, this is a huge study. It's and basically what the researchers were doing, what the study was doing, was trying to assess the long-term impact of adverse childhood experiences such as physical, emotional, or sexual abuse, death of a parent, divorce, mental illness of a parent, substance abuse by a parent, incarceration of a parent, witnessing a violent act, especially if it was someone close to them. Here's what they found. The more of these experiences a child had before age 18, and this is a cumulative effect, the greater the likelihood of a number of negative social and economic outcomes, including lower graduation rates, adolescent pregnancy, sexual violence, poor work performance, and financial stress. High ACE scores are also associated with smoking, depression, a host of chronic diseases, including alcoholism and substance use disorders, heart and liver diseases, and early death. One study by the Substance Abuse and Mental Health Services Administration found that every additional ACE increased the likelihood of early initiation of illicit drug use by 2 to 4 times. Now, let's combine that with a couple of other data points. There was a study that came out of Duke very recently, I think it was published in August. Children of incarcerated parents are 6 times more likely than other children to develop a substance use disorder. Now, let's go back to what are some of the changes that have occurred in our society since, say, the 1970s? War on drugs. This is 2012 data. It's probably changed a little bit, but not all that much. In 2012, we were incarcerating people at 3 times the rate we were in 1980 and 4 times the rate we were in 1970. We're putting all these people in jail, okay, huge percentage for crimes related to substance use or misuse or dealing. And we haven't really factored in the impact on the children. Look at the opioid epidemic. Here's something else that we know. 2/3 of all child maltreatment cases involve substance abuse. In 2017, 64% of all the kids who were removed from their homes by DCS, parental substance abuse was a factor. And then we have the kids who have lost parents and overdosed and died. All these kids are building up pretty high ACE scores. We have thousands of kids like this in this state. And if, as a society, we don't do enough to help mitigate that impact, we and those kids are going to pay heavy prices. It's not going to be very hard in the future. We have a lot to do to try to help support the kids who are affected and their caregivers. There are a lot of grandparents in this country who are in this state and in this country who are raising children. I know 2 sets of great-grandparents in Kokomo who are raising their great-grandchildren because the grandparents and the parents have substance misuse problems. So these are some of the factors that I think we really haven't gotten at. And one of the reasons we haven't is because we've had a tendency in our country. Brent Freeman back there he and I were talking about this a few minutes ago because he heard me talk about this at Goodwill, about the way we tend to treat, how so many social problems are interrelated and yet we tend to treat them in isolation one from another. The public sector has a tendency to do it through silos. One of the reasons my job was created 3 years ago was to make sure that doesn't happen when we're dealing with this issue at the state level. Make sure that we're all, as various state agencies, are coordinated, aligned, and focused, that we're all on the same page. And then in the not-for-profit sector, the other helping sector, incredibly fragmented. A lot of organizations doing a lot of good things, but each one typically working on a piece of a larger, more complex set of issues. And we really don't have any simple problems. We have nothing but complex social problems. And we try to treat them as simple problems. There are no simple solutions to complex problems. So what we've got a lot of good pieces out there. We have not done a good job as a society of connecting those pieces in a coherent way And that's one of the things that we're really putting a lot of emphasis on now. I'm sorry, I'm going on and on here, as I knew I would.
You need to be more passionate.
Problem I've had.
And I think Jim really segued into the next question perfectly, and I moved on above you so that we can have some of those stats that you were talking about. And the question is, how does this affect our community in general? If we're talking about India, what are the real societal effects that's happening on our community today? And you touched on kind of parental substance abuse and what happens to the kids and the ACEs scores for trauma. Robin, do you want to jump in a little bit on some of those societal effects?
Well, we certainly know about the overdose epidemic. So again, the thing that has been in the highlight, I think, of this opiate epidemic is so many people are dying quickly. So with alcohol use disorder, it's the disease progression, and I'm not saying people didn't die young, because they do in automobile accidents and those types of things, but generally, there was time to kind of work on the problem. And relapse didn't necessarily mean death. But with this particular epidemic, we're in quite, we've got overdoses to take a look at. That's a horrible, horrible thing. I don't want to, segue into the good news about that, but I do think that the overdose has brought this to an attention at the level where we've got this position, and we've got state government looking at this, and we've got $50 million from IU in the Grand Challenge initiatives, and all of these great things, because I think now we're dealing with it because we're seeing so many people die so quickly. But that is one of the effects of the overdose. I think it's something that I have to start out with is the first effect. And then the other thing is just the economical impact. This affects every area of every aspect of the person's life. So they become not only socially bankrupt, but they become financially bankrupt. I just talked to a client who, at age 21, lost a parent at a young age, trauma, had a trust fund of $100,000 he got when he was 21. He spent $45,000 in heroin in 90 days. He had spent that whole entire trust fund before the year ended, and now he's financially bankrupt. So guess what he did? He had an addiction that was something that had to be fed. So he turned to criminal behavior. So why did Indiana, it's no surprise that Indiana led the country in pharmacy robberies 1 year recently, because people will do whatever they have to do to use their drug, because it's not because they want to, it's because they will, everything else becomes secondary, and it's almost like they believe they have to do it to survive. So we see things like, a woman overdosing in her car with her 2 kids in the car seat and, in the back seat. And I think, how can a mother do that to her children? You have to believe that mother used that heroin because she believed she had to live. She did not do that because she wanted to put her children in jeopardy. So we are seeing any kind of societal effect you can imagine, that's going to be a result of it, because every aspect of that person's life is going to be affected by their addiction.
Jim and Robin have covered.
Sorry.
No. I really echo everything that they said, and it just in particular how far-reaching this disease is. And it is something that hijacks your motivation and your behavior. And so that literally is something that touches every single part of a person's life, and subsequently every single part of society. Absolutely.
And I know we mentioned earlier 75% co-occurring, and I think on MidPAC we have a recent state report of suicidality in the state of Indiana. And one of the stats that completely blew me away was in high schools, 1 out of every 10 students has attempted suicide in the state of Indiana in 2018. 1 out of every 10 high school students have attempted suicide. I was blown away. I had no idea that it was that prevalent in the state of Indiana.
Yeah, there was another study, 8th graders who are heavy users of social media are 27% more likely to be depressed. I think it would be really hard to be a kid today. There are so many pressures that I didn't have to deal with as a kid. And I feel really fortunate that I grew up without it in a lot of ways. But we have, there was some other, yeah, again, 1950, less than 10% of households were single parent. Now about 30% are. The majority of children born to women under 30 are born in single parent households. I was out at the Pendleton Reformatory a week ago, last Friday, and in the juvenile wing, and I was talking to the board, and I said, commonalities do you see in these kids? And about 240 kids out there at the time. And single parent households is number one. Now, all these factors, they don't have to be destiny, but it means that we need to recognize the risk factors. We need to recognize the risk factors. We need to make sure that we're doing enough to try to help mitigate the impact. High ACE scores don't have to be destiny. They really don't. There's a genetic component to addiction. It's not the whole thing. It's a piece of it, but it doesn't have to be destiny.
Well, this is a perfect segue. So I think we understand there's a problem, and there's a lot going on, and it starts early on, and it affects kind of the whole household and everyone around. So what are we doing in the state, in Indiana, to really fix the problem, to deal with the issue? So I'm going to have Robin kind of kick us off here, and then we'll kind of work down.
Okay, well, we're doing a lot of things that I think at the state level that I think Jim would be the better person to speak on. But I will just kind of talk about some of the things we said earlier, right? That we have to start to learn to address the core issues and the issue of the problem. So I think the way we deliver treatment has changed dramatically. We've changed our approach dramatically over my span in treatment. It used to be, we have developed things, embraced harm reduction models. We can't help a person address all of these complex issues if they're dead, right? So, and we don't want spread of secondary infectious disease like HIV and hepatitis, like we saw the outbreak in Scottsburg not too long ago, and in all of the communities that have needle epidemics. So needle exchange programs are incredibly important for us to support. These are all things that are just kind of hard to think about. They're not things we want to have to do, but they are things that are going to save lives. I know medication-assisted treatment has grown, and we're putting a lot of emphasis on this because we've got to keep the client alive long enough to address the social and emotional things that have to be addressed. Now, the medication alone, the needle exchanges alone, the other harm reduction measures are not in itself going to treat and change that person's life, but hopefully we'll be able to have access to those people. So I think increasing harm reduction, increasing prevention, understanding the social determinants of health, and then the other thing that I hadn't planned to talk about, but will, is, Jim mentioned the fragmentation of the systems. We can't operate like that more. We have to take an integrated approach, and so, Fairbanks is now integrated with Community Health Network, which is now part of the CART, which is, we don't like that word.
I don't like that word. Comprehensive Addiction Recovery Network.
Network, we're going to call it CARN. But that will now partner us with Eskenazi and Midtown Health. So we will all be part of one system so that we can be focused on the client, not focused on the system of care, and break down some of these silos. So I think that's one of the things I just thought we could highlight as a great first step.
And that's really, it's a recognition of the fact that we have been program rich and systems poor. We have not had good systems. We have had this fragmentation of all these various services. And so but one of the things that we did early on, we recognized we don't have nearly enough access to effective treatment, medication-assisted treatment for those with opioid use disorder. And so we put a huge emphasis on increasing treatment access, timely access to treatment. And we made some good headway there. There's more coming. But here's some of the things. And we need a lot more recovery housing. We need more recovery supports. People who are coming out of prison, people who are in recovery from treatment for substance use disorder, they need ongoing support. I mean, basically, those two groups of people, by and large, we're talking about adults now, they need three things. They need a decent place to live, safe place to live, they need a job, they need a support group. They need people who are going to wrap themselves around, support them. Huge. This is a role that churches could play to a much greater degree than they typically do. Randy Davis is a retired United Methodist pastor in Red Key, Indiana. I never heard of Red Key, Indiana before I started doing this work. Randy has started 35 support groups composed of volunteers. Most of them are church-based. We're all over the state and some in Ohio, basically to wrap themselves around people who are struggling with addiction and their families. So we have to do more of that. But bringing all these pieces together, these comprehensive addiction recovery networks, we announced grants to 3 different entities, including the one that Community and Eskenazi are part of, basically to provide a full spectrum of services and a smooth continuum of services, from intake, through treatment, through recovery supports, and with links to wraparound services for these individuals and their families. And we cannot forget the families. One person may have the disease, the whole family is suffering. So bringing this all together, we're supporting 10 broad-based cross-sector coalitions in communities around the state, where people are coming together from business, education, healthcare, local governments, law enforcement agencies, and the courts, philanthropy, faith-based organizations, community-based organizations. They're coming together with a focus on prevention, treatment, and recovery, and they're getting to know each other, people who formerly might not have ever had any reason to know each other. They're learning about each other's different perspectives and their capabilities. They're finding ways to work together, leverage resources to cause some good things to happen that otherwise won't happen. And in every one of these that we're supporting, there is strong local leadership. Where you don't have that, not much is happening. So it does take leadership, and it comes from different places in different communities. But there's always one individual or a small group of individuals who say, we got to make something happen here. They get the right people around the table, and they start making things happen. So these are some of the kinds of things we're doing. The prevention emphasis on youth, oh my gosh, I could talk for another hour about that one, but that's another one where we really need to be doing a lot more, and that's one where lots of different organizations can play a role.
Wait, what was the question? Yes, all of this. So I can talk a little bit about also just from the perspective of a healthcare organization. What are we doing also as part of the response? There are really, I think, 3 important areas that we try to focus on. So one, prevention, of course, and from a healthcare institution perspective, in distinction to the very, very important social aspects that Jim is talking about, responsible pain management and opioid prescription is a really important effort for us. And so there's actually been a lot of legislation about this in the past couple of years, but we've made really enormous decreases in the amount of opioids that we are prescribing. And so we're in part limiting the supply, limiting the exposure, and also just finding appropriate ways to manage pain that do not involve opioid medications. And so that's a really important part of preventing that initial exposure. So also treatment, of course, we've talked a lot about that. I'll just mention also that I want to make a distinction between detoxification and treatment. So getting an initial detox is a very different thing than receiving ongoing treatment for addiction. And so I think that sometimes people conceptualize treatment as the detox, and we just need to get someone in a hospital and give them a chance to detox. And while that can be a very important part and a very important step in someone's recovery, just getting the drug out of a person's system and getting beyond those initial withdrawal symptoms is really only one step. They need really a minimum of 90 days of treatment, and many people need at least a year, and on many people even more. So again, this is a chronic relapsing disease, and so it's not at all a sign of failure if someone continues to take medication for many years. That can be a very important part of people's treatment. And so treatment obviously is very important, and then also harm reduction. And Robin, I'm really glad that you mentioned the needle exchange. Naloxone is another important part of harm reduction. There's been a lot of raised awareness for naloxone. It's an overdose prevention drug. That's a drug that helps reverse overdoses on opioids. So that keeps people from dying. And Robin, as you mentioned, someone can't begin their recovery if they're not alive to experience that. And so we want to make sure that naloxone is out there in the community and it's available and that people know how to use it. I read you're more likely to need to use naloxone than administer CPR to someone. And so that's something we want to make sure is accessible. The needle exchange program is also a very important part of our strategy as a public health effort to help move people towards recovery. There's been decades of research on needle exchange programs. They do not increase drug use, they do not increase crime, and they do, in fact, get more people to engage in treatment, and they reduce transmission of infectious diseases. And so those are really excellent programs to help move people towards recovery. So we definitely support those, and we're glad that Marion County has created a needle exchange program.
I was just going to add one thing what I miss in this conversation is, we have a real shortage too of behavioral health professionals. It is not something, and so I think one of the big things we have to do as a network of providers is support workforce development, and
this is a whole other soapbox. I'm going to restrain myself right now, but this is, as an institution, this is also an enormous area of need. And so this is also an area that we're looking to the state as well to partner with us because there is a huge workforce shortage that keeps us from being able to serve the number of people that we need to. So like I said at the beginning, we're reaching maybe 15% of the people in the county that need services, that just our institution alone. I heard a statistic the other day, the National Council for Behavioral Health estimates that across the country, we have only 26% of the mental health workforce that we need in order to meet the needs of people across the country. So it is a huge, huge issue.
Yeah.
Awesome. And thank you for explaining the detox to recovery comparison, because a lot of people have this misconception that someone's going to go get treatment, they just go do 30 days, and then they come out and they're fine. And so it's really important to understand that recovery is a process, not a quick spin dry.
Right.
One size does not fit all.
Absolutely.
Right, totally.
Different people need different treatment.
Exactly, and as you all have mentioned, like it is such a far-reaching illness that recovery looks different for every person, and so finding the right supports and employment and relationships in order to help someone along recovery is something that is very, very individualized and very highly customized. So medication can play a very important role for people. Another myth, I know we're getting close to time, but there exists, unfortunately, the myth sometimes that using medication as part of treatment is replacing one addiction with another. And I truly hope to, if anyone does believe that, please come and talk to me. That is not in fact the case. And medication can be a very, very important part of people making very meaningful and very important recovery.
So I want to go through a couple things relatively quickly, and then I want to make sure we have a few minutes to be able to ask some questions. So the next thing we wanted to talk about briefly was how can we get involved? What can you do to kind of participate in this process? In your folders, I've got a handout that Jim provided to talk about some different opportunities where you can get involved and participate. Up here, there's just some really simple things. But I want to open up to you guys for 2 or 3 minutes to just talk about kind of what do these mean, how can somebody get involved, how can we as a community participate in the recovery process. Yeah, go ahead.
Well, another myth is that somebody has to want help in order to be able to get help, and that is absolutely not true. There's a lot of evidence out there that it doesn't matter how a person gets to treatment, it matters what happens when they get to treatment. So don't think just, you hear, oh, they have to hit rock bottom, or if they want help, I'll be there to help them, but otherwise not. No, interventions, supporting people, encouraging people. I just tell people, don't give up, you know, just because they say they don't want help doesn't mean they don't want help. They just don't know, they feel hopeless, and many times they just don't believe they have hope to get recovery. And so providing them love and support and hope, interventions are incredibly successful. And even, you know, extremely motivating people, backing them up against the wall. There's, you know, I have no issues with court ordering someone to treatment, or a spouse saying you go or else, or a parent saying you go or else, because we can change that in treatment. We can change that external motivation to internal motivation once their brain clears enough from the disease to be able to see it. So I think that's a way that we as a community can help families be there and encourage them to help. So that kind of gets into the educate yourself to, you know these myths they're just not true.
Right. And we, as healthcare providers, there is no way to predict that someone isn't going to recover. So there's no point at which we would say as healthcare providers, no, this person's not going to recover. It's not worth investing in their recovery, because everyone can recover. And so it's always worth the effort and the hope and the optimism to assist someone with whatever they're willing to.
Well, you put all this.
Yep, that's in the folders, yep.
Well, I'll just mention a couple things. Mentor a kid. Mentoring programs can be really effective. Support organizations that provide after-school opportunities for kids. That can be really, really helpful. If you want me to, I'll tell you what happened in Iceland if you want to come up after. We don't have time to go through this right now. But with after-school programs, schools and other organizations are providing evidence-based substance abuse prevention programs for kids. There are some good ones out there. They're not substance-specific. They teach people how to manage these kids, how to manage emotions, how to cope with challenges, how to develop resiliency, skills that are useful throughout life. It's social emotional learning is basically what it's called. Really, really important, especially for these kids who are at high risk. But any situation where you've got kids who are at high risk, their families are at high risk, do anything you can to try to help support them. It's a really good way to try to reduce the incidence of substance misuse and abuse.
And I appreciate the fact that you said accredited agencies, and there's a lot of different shops that are around that claim to be helping people. And it's important to look at facilities that have the correct accreditation. If you're going to donate your time or your money or your efforts or your energy into something, I would highly suggest that you educate yourself about it a little bit to make sure it's an accredited facility that uses evidence-based practices. The other one we had up there was talk about it, and I'm glad Don started off with that icebreaker. It's hugely important that we talk about mental health and addiction and substance use disorder. So many people don't get help because of the stigma that exists out in the community. And the more we talk about these disorders, the more likely people will feel comfortable to reach out, to ask for help, and go somewhere and get treatment when they don't feel like they're going to be judged. So engaging, embracing people, having those conversations is hugely important.
Stigma is a huge barrier to effective harm reduction.
And it's a perfect segue. So on the Indiana Recovery Council for the state, one of the things that we're currently doing is the Stigma Never Helps campaign. That's kind of been pushed out. So I have two quick 30-second little videos to
Do you speak?
You think I would practice this right before we start?
Do you speak stigma? person with a disease like mental illness or substance use disorder hear the negative labels that others call them, they leave a mark. Words matter, and what we say and do can stop people in need from seeking help. Now's your chance to change lives for the better. Visit stigmaneverhelps.com to find out how.
This part of having bipolar disorder is this little bitty part that actually doesn't tell you very much about you. Stigma can affect people with substance use disorders and mental health in that they don't get help when they need it. I'm very proud that I've been able to recover to the point where I can work full time, I can make a difference in my job, that stigma can help prevent us living fully because stigma never helps.
So I like
This part of having bipolar disorder is this little bitty part.
I like sharing those just so people can see kind of the real effects that are going on in our community. The young lady who was just in that video, there's a longer one that you can kind of check out. It's about 4 to 5 minutes long, and she really talks about more in depth of her story. But she's actually the director of Key Consumer Organization, which is a nonprofit that works with mental health. And she was in a treatment facility where they told her that she should not get pregnant because they didn't want her to pass on her mental illness to her children. And for years, she did not want to get pregnant because she thought that she would pass along her disease to her children, and that was a horrible thing that she should never do. And it's sad that in an institution, employees were having that stigmatizing language and saying those things to patients who are going there for help. And so when we talk about, educating ourselves and making sure we understand what these things mean, and genetics do play a part, but they are not the defining part, and how all these things interact together. So I just like to share those and have them available as a resource. So what I'd like to do now is we got about 10 minutes to open up for a few questions, make sure you guys get a chance to ask a couple things, and see where it goes from there. So does anybody have any questions? Sir?
For those of us who have grandchildren in elementary schools, the available resources, assets, if you will, that are being used throughout the school systems for education regarding avoidance, etc., whether it be alcohol, drug abuse, etc., are those being utilized? If so, and if not, who are the high achieving, high performing schools in the area that are doing the best work in your opinion?
I would say that it's very spotty. We have provided some additional resources to DOE this year to expand the use of some of these evidence-based programs. There are programs, there are private foundations here in Indy. The Richard Fairbanks Foundation has made available $12 million to public schools in Marion County to enable them to implement evidence-based programs in the schools. I forget the number of schools that are taking advantage of that, but it's significant, but it's not all of them. And then there are private foundations up in LaPorte County and also in Tippecanoe County that are doing likewise, modeling what they're doing after what Fairbanks Foundation is doing here in the city. So there's some of that. Would like to see a lot more. I will have to tell you that I have not encouraged mandating this because honestly, I think we have put so many mandates on our public schools. We expect them to solve all our social problems. They don't have the resources to do it. I'm very sympathetic to the situation, and I would like to see more of this. I think there are some systems that are doing better than others. We provided some other some financial resources for an organization that's working in several counties down in the southwestern part of the state as well. But again, there's a lot more that could be done. There is a list of Substance Abuse Mental Health Service Administration has a list of evidence-based programs that they have approved. It's very similar to what, in fact, that's where Fairbanks got their data, and they did research a lot of this.
I would just add, don't be afraid to talk to your kids grandkids about drugs and alcohol. They're talking, I think that's part of the stigma thing, you know, we're afraid to talk about these things. We think, oh, if we talk about them, we're putting that in their mind. But what we know is that kids will get their information from somewhere, and we would prefer to be able to talk to them than for them to get it from their peers. So what we know also through these studies, just real quick, is if you have your high school kid going on spring break, they're more likely to do what the other kids are doing that they're with than they are to do what they know and have been taught to do, which is really kind of a scary thing for a parent to know. So knowing that, it's really, really good to know who your kids are hanging out with, what they're talking about, ask them what they're talking about, and try to get involved in the conversation because they are more, you know, especially in the adolescent years, they're more influenced by their peers than they are by their own decision making in a lot of situations. So.
And any addictive substance has a more powerful effect on the developing brain of a child or an adolescent than on the more fully developed brain of an adult, which is one reason why we need to keep any addictive substance away from young people as long as we possibly can. It's one reason I am just really concerned about the whole vaping issue these days. I'm very, very concerned about that.
The earlier the exposure, the more likely of later use and abuse later on.
Most people with alcohol use disorders say they started using around 13 or 14 years of age. And if you survey people who didn't start drinking alcohol until after age 21, the rates of alcoholism significantly decrease. So the longer you can keep them abstinent, the better.
I have to do one shameless plug. There's one recovery high school in the state of Indiana, and it's here at Fairbanks High School. It's Hope Academy, and there's 23 across the U.S. Yeah, 23 to 30 recovery high schools across the United States. But there is one here called Hope Academy, and it's an awesome resource for kids who are really struggling with substance use disorder. Yes, sir.
Doctor, you talked about how dopamine is kind of a natural reaction to things that makes us feel good, and how that goes away with drug use, the ability for that to work.
Right, it's dampened.
After a time through recovery, does that come back?
Yes.
Oh, it does.
And that's part of the recovery process. That's part of why abstinence is important, is because it does actually allow the neural circuitry to heal itself, and so that you are able to restore some of the executive functioning, some of the normal reward circuitry.
Dr. Oakley, correct me if I'm wrong, 5 years for the brain to fully return to normal?
You know, I don't know. I know that 90 days is really kind of a bare minimum.
Yeah.
That within 90 days, that's when we're able to start to see the evidence that the brain is healing.
Yes, sir.
Just curious how you, and Jim, this might be a question for you, how you view the partnership with law enforcement, and are we doing enough to train our police officers? Because I'm guessing that the statistics would suggest that mental illness plays a huge role in crime.
It does, and you find that we have a jail overcrowding task force right now. I'm retiring from this position January 9th, and Doug Hunsinger will be my deputy for the last 3 years, and he's going to step right into that role. Doug is on that task force. We've been working very closely with the Sheriff's Association. We've got some sheriffs. Basically, what we want to do is provide, we want medication-assisted treatment in the jails for those who are there long enough to get started. We also want buprenorphine induction in the emergency departments, but in both cases followed by a warm handoff treatment in the community. Here's what happens. If you go into a jail, the jails have unfortunately become de facto detox facilities in many parts of the state. And if you're in the jail, you detox, you don't lose your craving, you get out, but you do start losing your tolerance. And when you get out, you are more susceptible to overdosing and dying than you were when you went in if you haven't had treatment. So if we can get people, and the statistics on that are really bad. If you can get people if you can start treatment in the jail, we're doing this much better in the prisons, state prisons now than we were But if you do it in the jail, provide the warm handoff and treatment in the community, you have a much higher retention rate in treatment in the community. And it's a way to, again, to increase the effectiveness overall. Some of the sheriffs want to do this, some of them don't. There's an education process going on similarly with the judges around the state. There's some who get it, there's some who don't. There are some really good drug courts in the state. Medication-assisted treatment combined with the supervision of the drug court for 18 to 24 months, highly effective. Some really good ones around. We're providing support to expand family recovery courts. These problem-solving courts can be really helpful in many, many situations. And the Chief Justice and the entire Indiana Supreme Court has really been active in this field. They are really, the Chief Justice has been a huge, huge advocate for this. So, and she has a lot of influence over judges around the state. So there's some good things happening. It's not where we'd like it to be, but there's a growing percentage of law enforcement officers around the state who really do understand this, and they know we cannot arrest our way out of this problem.
Yeah, I'd like to add as well, another Marion County project that we're working on right now is a partnership between Eskenazi and Marion County on developing the Assessment and Intervention Center, which will actually be the first building to open in the new community justice complex in the Twin Airs neighborhood. It will be a 60-bed facility that will serve as an alternative to incarceration. And so for individuals who are eligible from a legal perspective and have some mental illness, homelessness, addiction, they'll be able to go to this assessment and intervention center instead of becoming incarcerated, with the goal of engaging them with whatever support services they need in order to be successful and move forward in recovery. So engagement with treatment services, financial resources, housing, employment. Our hope is that we'll be able to help coordinate engagement with all of those services through this assessment and intervention center.
So first, I'd just like to thank our panel today. I encourage everybody, if you want to stay and socialize afterwards, to kind of head out in the lobby and hang out. I got to be respectful. We have another group that's going to come in here. It's actually a family support group that's going to be coming in afterwards, so I'm going to help get that set up. But if Don wants to kind of close us out.
Let's give Matthew a big round. Well, we'd like to thank you all for coming. I think it does reinforce the importance of relationships. As we hear loneliness and hear community and support, and hopefully we model that in the way in our lives. Sometimes people ask me what's special about Indianapolis and why are so many good things happening in the faith community and just people, personal philanthropy, and I said because the relationships are deep. People truly care about each other. So thank you all. Have a great Thanksgiving, and look forward to our next session. Thank you. Great.